Thanks for the invitation here. So I'm going to be talking about our product, KlioCarePlan, and the company, of course, is Clio Health. I'm one of the co-founders, and I have spent about 13 years in the healthcare world, largely across devices, acute care monitoring systems, and over the last 5 years, have looked at patient monitoring and patient management systems, and found my way into healthcare IT. Basically, at the dawn of Obamacare, and I've sort of lived through various sort of start-stops, both on the private sector as well as public sector, and everything that CMS has done. And a lot of what we're doing now with Clio applies to both commercial payers and commercial health plans and commercial contracts, as well as employee-sponsored and private payers as well. I'm going to jump into why this is important today. This applies to any provider, whether you're a 5-person practice or you're a 5,000-person healthcare system. And what it boils down to is value-based care, which is essentially making sure that what you're paying for actually is going to make you better, not just do stuff to you when you walk into a hospital or a clinic. They just, they're so compelled to do stuff because you're there and they have to do something, so they just do stuff. Right? And without actually figuring out whether what they're doing is actually making any difference or not. And so value-based care is here to sort of change that. And there are reimbursements tied to value-based care, which essentially represent 11% swing in revenue. So we are trying to make sure that as a practice or as a health system, you're on the right side of that 11% equation. And there's need for quality surveillance, which is essentially tied to your reimbursement targets, and a larger sort of emphasis on a more population-level health benefit or population health management, as it's often used in the public health speak. So why is this important? Well, we can sort of look at best-in-class, best-in-breed EHR systems, and they're just sorry. You look at Epic, you look at Cerner, you look at Practice Fusion, and they're really poor. They're really adopted from a billing management system that sort of somehow got co-opted into doing sort of patient management, but it was really, really poor. And what they get even worse at is when people need to go from one kind of practice, whether they're getting care at a surgery center and then they're moving off to a PCP, or they're getting care at a hospital. Yes.
What's an EHR?
Electronic health record. And what they're really poor at is essentially managing this continuum. And the reason this continuum is so complicated, as you can see on that chart, patients can move in and out of these various different care settings across these various different care delivery providers, whether they're a primary care practice, a home health agency, a patient-centered medical home. And if you have complex care needs, you are going back and forth between this sort of soup of providers and care need network of things. So what we're doing essentially is developing a ability to actually dynamically adapt care plans and care transitions across no matter what care provider you're at, or what kind of complex or simple care needs you might have. And each care transition when it occurs essentially enters our system, and we update your care plan based upon data that we're reading from EHR systems. So we integrate with the top 5 EHR systems using standards-based protocols, which are actually recently released and have moved from standard, non-standard document-based protocols to a REST-based standard. We have 2 applications, one for the provider and one for the patient, and we're going to walk through the provider. You can sign up and sign in as a provider. You can triage your patient according to everything that the EHR is telling you and what you're reading from the EHR. You can look at them from a treatment adherence or medication adherence standpoint. You can look at them from a risk assessment standpoint. You can look at their specific care plan, which is dynamically generated from EHR data. Here, the patient has MS and chronic kidney disease. They also have sort of mild depression, so they're indicated for taking surveys every 3 to 6 months. In this case, I'm essentially saving a patient's MS diary, which is assigned to by the doctor. In addition to this, they can look at trends for this patient, which allows them to longitudinally look at data as well. And similarly, on the patient side, you can look at a very quick snapshot of what you need to do on a day-to-day basis. You can look at your treatment indications that you need to be staying on top of. You can look at how often you are complying with your medication regimen. And this is all configurable for any disease state across any care environment.
How do you make money?
So what's interesting is because there's been changes in the reimbursement policy, there are allocated dollars tied to specific reimbursement codes that go towards both chronic care as well as home care. And of course, our pricing model is tied to 10 to 12% of the revenue that we will get from caring for patients at home. So this is sort of either you're being cared for to essentially make sure that you're not coming into the facility. So providing care at home.
If I'm a patient, do I have to pay extra for this service?
No, you're already paying for it through your deductible as well and co-pays. So this is something that's already been covered, so you're not paying extra for this. This is something that's being charged by the provider. Go ahead.
At what level do you need adoption sign-off? Who has to sign off?
So that depends. That's a good question. That depends on the customer segment. So if it's a five-person PCP or a specialty care practice, it's a very quick sell from a customer acquisition standpoint. But when if it's a, let's say, 200,000 patient healthcare system, then you're essentially talking to a CMO, CMIO, and you are making an enterprise sale. I mean, they're all enterprises. Essentially, it's a small enterprise or a large enterprise.
Would it make sense to just focus on the smaller practices first?
Yes and no, because the bigger practices essentially also dictate a lot of the big dollars being spent. And given the changing healthcare system in terms of sort of acquisition activity, especially in the Boston area that we've already witnessed in terms of smaller practices and smaller hospitals being acquired, that trend is only going to pick up and keep pace for the next 5 to 10 years. Go ahead. Let's go ahead.
What have you done user trials? I guess, or is this live?
This is live. So we have so we have about 2 hospitals that are using the system. One for a post-op care situation, and the other for specialty care. And we have about another 5 that are ready to go in July. So in another month's time.
What's the user retention rate look like on this? Because it requires some measure of user volition, kind of like internal drive to access the site.
Right. So gold standard for, if you look at EHR, is about 5%. That's how poor it is. Where for different care settings we have benchmarked. So for post-op care, we're actually at 85%. For chronic care and specialty care, it's more like 67 to 73%.
So is there a mobile app associated with this too?
This is completely, so yes, it's completely responsive. So it works device agnostic.
Okay.
Yeah. Go ahead.
Where are you getting the EHR? Are you getting it directly from the hospitals?
We're plugged into the HL7 stream that's coming out of the EHR system. So Epic, Cerner, Practice Fusion, Athena Health. Go ahead.
So to ensure continuum of care, should all the providers be on the system so that you can then have a complete picture?
So if you're a healthcare system, most healthcare systems also don't have the same provider, which is a great question. However, as we're moving towards, there's a new standard called FHIR, which is, so I can sort of nerd out on standards for another half hour if I had to, but long story short, we're moving away from a document-based sort of, here are all the fields and it looks like an XML document to here is a JSON feed, figure it out. And so we're sort of essentially transitioning from, an XML world to a JSON world finally.